Hi everyone, this is Dr. Terri Messman-Moore, and in this audio lecture I want to talk about somatic symptom disorders. This is part 2 of the series differentiating malingering, factitious disorder, and somatic symptom disorders. So if you haven't already, I encourage you to watch the earlier video before watching this one. So somatic symptom disorders involve a group of disorders where we see physical complaints or symptoms that may look like illnesses or diseases, but there's no physical explanation for those complaints. In other words, there's no pathology that can be identified through different forms of assessment. So there doesn't appear to be an underlying physical reason the person has these physical complaints. However, we would distinguish this disorder from conscious malingering. Remember, conscious malingering is where people are intentionally producing symptoms or what looks like a disorder or an injury in order to achieve secondary gain. In this case, there's no conscious or intentional, purposeful development or production or feigning of symptoms. We see generally 3 main disorders within this category. Somatic symptom disorder, which was otherwise known as somatization disorder in earlier iterations of the DSM. Illness anxiety disorder, which was formerly known as hypochondriasis. And conversion disorder, which has also been called functional neurological symptom disorder. Now coming back to this chart, the key here is that we are distinguishing between individuals who are engaging in conscious attempts to produce what appears to be physical or medical-like disorders or conditions versus unconscious attempts. So again, it's really important to remember that all of these disorders that I'm going to talk about in this video are focused on unconscious attempts. So somatic symptom disorder is a very broad disorder, so it kind of involves a lot of different types of symptoms by design. So if you're at all familiar with the medical model and how we diagnose medical conditions in the United States, you know that these conditions hang together in what we call syndromes. So we tend to see certain symptoms or signs that go together. In the case of somatic symptom disorder, we are seeing a lot of different complaints across systems, and so they don't always make sense medically. So let me show you what I mean. So we tend to see recurrent and multiple somatic complaints. These are without an organic basis. Organic means a physical etiology. And the earlier diagnostic criteria included having a number of different symptoms across systems. So for example, 4 pain symptoms in different locations, 2 gastrointestinal symptoms, 1 sexual symptom, and another pseudo-neurological symptom. So they used to have a lot of different symptoms and across different places. Now with the revision of the DSM-5, they only need 1 or more of these symptoms, but they must be distressing and very disruptive to the individual's functioning. Now, individuals just can't have these symptoms. There needs to be additional factors at play to consider the diagnosis of somatic symptom disorder. In this case, we are focusing on whether there's the presence of excessive thoughts, feelings, or behaviors that are related to the symptoms. So with this disorder, we tend to see disproportionately anxious or negative thoughts that are quite persistent about the symptoms or the experiences. And these individuals tend to have very high health-related anxiety. So they tend to really think about bad things that can happen in terms of their health. They tend to interpret potentially neutral or benign physical sensations as a sign of disorder or disease, and there seems to be an excessive amount of time or energy that is devoted to their symptoms or their health concerns, and that could be excessive time where they're examining their body or charting their symptoms, but it also could be excessive time where they're learning about particular disorders or doing research. Now, the older disorder named somatization disorder, the worldwide prevalence is only about 2.8%. And you might not be surprised to learn that it's not that frequently diagnosed in mental health outpatient clinics because these individuals aren't interested in psychological treatment. They're interested in medical treatment. So we're going to see this much more likely in a hospital setting or maybe even an outpatient physician's office. We do see a gender difference. It's much more common in women, but the symptoms vary by culture. So there's going to be almost like culturally bound syndromes that go with this disorder, but yet somatization disorder itself is found across societies and across the world. The other linkage to demographic factors is that this disorder tends to be more common among people who are of lower socioeconomic status. Now, illness anxiety disorder, I'm sure you've heard of hypochondriasis. Or I'm not a hypochondriac, or I am a hypochondriac. So illness anxiety disorder is different than somatization disorder because with illness anxiety disorder, the person has a preoccupation with a disease. So with somatization disorder, they're really looking at symptoms and they're kind of all over the place and they don't seem to fit together. They're not systematic. This is almost the opposite of illness anxiety disorder. With illness anxiety disorder, we see the individual who's really thinking about, oh, I have cancer, for example, or I have a brain tumor. So if you haven't seen it already and you like Woody Allen films, the film Hannah and Her Sisters, which involves Woody Allen as a hypochondriac, is really interesting because he shows very well how individuals may latch on to particular findings from a medical assessment or testing and take it to the extreme to thinking that they have a life-threatening disease. So those with illness anxiety disorder tend to have extremely high anxiety, but they don't have a specific focus. So it's kind of different. They have more of a focus on having a disease, but they can't really do a good job telling you what symptoms they have. So the somatic symptoms are either absent or they're very mild if they're present. And that's in contrast to somatic symptom disorder where the somatic symptoms are the prominent part of the disorder. Individuals with this disorder tend to really latch on to scientific descriptions and use scientific terminology to explain their experience to their doctors. This kind of harkens back to some of the symptoms that we see among people with factitious disorder, for example. And these individuals will report really vague complaints of uncomfortable and unusual sensations in their body. Not surprisingly, individuals with this disorder also tend to misinterpret bodily sensations. So these individuals are very sensitive to changes in just basic functions like respiration or heart rate, and they tend to misunderstand what changes, especially sudden changes in these basic aspects of functioning, what that means. There tends to be a personality disorder that is associated with this hypochondriasis. So these individuals tend to be seek caregiving or seek out attention and support, or they can be highly avoidant of social situations. Again, we don't tend to see this very much in an outpatient psychology clinic, but the prevalence in general medical practice is actually very high. Between 4 and 9% of individuals will meet the criteria for illness anxiety disorder. Conversion disorder is very interesting. It's much more historically relevant to the study of psychiatry and abnormal psychology. So when we talk about conversion disorder, we're often hearkening back to the Victorian era where they were labeling a very similar syndrome as hysteria. So conversion disorder itself is still diagnosed, although it's less common today than it was in Victorian times. And this disorder involves actual physical disability. So there is impairment in functioning in some way, and it's typically connected to either sensory abilities or motor abilities or visceral symptoms. So let me go into that. The main thing that distinguishes conversion disorder from a medical condition is that there's no organic pathology. So again, there's no reason medically why these individuals have these symptoms that they're reporting. So again, we're always going to start our assessment of conversion disorder with a rule out of medical explanations. So once we know that there's no medical explanation, we're going to be looking for other patterns. Conversion disorders tend to be characterized by what we call pseudo-neurological symptoms. So pseudo-neurological symptoms might involve dizziness, they might involve paralysis or numbness or tingling in particular parts of the body. And the classic example is glove anesthesia. And glove anesthesia occurs when individuals report that their entire hand is impervious to pain, or maybe they can't feel their hand. But this pattern of response actually is inconsistent with our current knowledge of physiology and anatomy. So I'm going to come back to that with another slide, but suffice it to say that individuals are reporting pseudo-neurological symptoms, but they actually aren't real. They're not possible based upon our understanding of physiology and anatomy. So these individuals may have conversion disorder either due to primary gain or secondary gain. The primary gain, again, is this idea that individuals are trying to obtain attention, or psychological needs are trying to be met through this behavior. But there can be secondary gain. So one classic example of the secondary gain associated with conversion disorder is during World War I, when pilots who were expected to go out on bombing missions during World War I actually developed blindness, so they weren't able to see. And this is a classic example of conversion disorder. In this case, the secondary gain was to escape from the possibility of being in war and being maybe gunned down or killed while engaging in their mission. So secondary gain is possible, but again, this is not the same as malingering. And one of the reasons it's not the same as malingering is because there is no intentional conscious awareness or faking of the symptoms. And conversion disorder is different from factitious disorder for the same reason. There is no conscious or intentional faking of the symptoms, even for psychological gain. Another factor that's quite interesting about conversion disorder is what we call la belle indifférence. La belle indifférence means that individuals will report very significant and potentially disturbing symptoms that suggest very severe medical conditions, such as a brain tumor, and yet they don't appear distressed by the implied severity or even morbidity of the condition. So in this slide, this figure, I want to show you the difference of what we see related to like the idea of glove anesthesia. So on the left are the left two bodies facing away and towards us are the actual patterns of neural innervation. So what this means is this is how our nerves actually run through the body. So what you can see on the left-hand side is the individual's hand. There's two primary nerves, one running kind of closer to the fold next to the thumb, and then one that connects in between the ring finger and the middle finger. And that those nerves run up and down vertically up into the shoulder area. And similarly, the nerves in the legs also run perpendicular to the ground. They run up and down the leg. But what's interesting is individuals with conversion disorder who are reporting anesthesia, like the being impervious to pain or some sort of paralysis, will often report symptoms in the areas that are highlighted in blue on the right. So there's some, if you haven't noticed already, there's some kind of obvious issues here. So they're not reporting that they're having anesthesia symptoms or difficulty with numbness or tingling or whatnot throughout the entire arm. In this case, the symptoms are from the elbow down in both arms. But if you look at how the patterns of the nerves in the body, this is not physically possible, because if there's problems in the lower part of the hand, we would expect it to extend up the arm. So similarly, we tend to see problems on the lower parts of the legs, but not in the upper parts, or across the knees, or in the upper back, but not all the way down the arm. So again, what we see here with hysterical anesthesias are that these symptoms are not anatomically possible. So there's different types of symptoms that are possible with conversion disorder. This is different than somatization disorder, where they would require symptoms across areas. In this case, they could just have one set of symptoms. It doesn't have to be across these 3 areas, but these are the most common areas. So sensory symptoms such as anesthesia, hyposthesia, where there's an increased level of pain, anesthesia, where they don't feel pain, paresthesia, where there's like numbness and tingling or blurred vision. Motor symptoms can include paralysis, aphonia, the inability to hear, mutism, the inability to speak, or convulsions that look like seizures. We can see visceral symptoms such as choking sensations or nausea, or even pseudo-pregnancy. And so what we're seeing here are what appear to be very significant medical problems that don't fit the medical explanation or our understanding of physiology and anatomy. So sometimes we want to look at trying to distinguish between conversion disorder and malingering. So remember, malingering is an intentional faking of symptoms for secondary gain. Conversion disorder is usually what we think of as unconscious and not intentional. So what are some of the key differences in terms of the presentation? With conversion disorder, there tends to be not always a rapid appearance of symptoms, but there can be. With malingering, there tends to be the symptoms appear in relation to the goal. So, for example, individuals may report a gradual appearance of symptoms depending on what type of injury or condition they're trying to fake. But with conversion disorder, it tends to just appear out of the blue, like very, very quickly. So for example, going back to the pilots in World War I, they might go to bed one night before their mission, and then the next night they wake up and they can't see. So it's very quick. Again, I already mentioned labile indifference. Labile indifference is important because most people who have severe or extreme medical conditions like I'm talking about, where they maybe are blind or they're paralyzed, these individuals are going to be very distressed about these symptoms, about the condition that they're in. But individuals with conversion disorder tend to not be distressed. Individuals who are faking it are going to act distressed. And finally, we tend to see selective symptoms that don't always make sense. Again, sometimes particular areas of the body being affected, for example. People who are malingering are going to do research to try to mimic and fake symptoms that would be consistent with what we know medically, and with disorders that might, or conditions that might provide the most secondary gain or financial gain. Individuals with conversion disorder often have selective symptoms that don't make sense physiologically, right? So they're not producing symptoms that would make sense from a neurological standpoint, for example. So how do we treat conversion disorder? There's several options: behavioral approaches, hypnosis, or problem-solving therapies. Oftentimes we're conceptualizing the presence of this disorder as meeting some sort of psychological need. And for example, in the case of the World War I pilots, it could be that the absolute fear and terror about entering into a war zone and potentially being gunned down. There is some evidence that hypnosis may be helpful for the treatment, and also problem-solving therapies. So again, if we think about conversion disorder as a response to extremely stressful conditions, problem-solving therapies can be helpful in terms of reducing the overall level of stress, and therefore, in a secondary way, reducing the likelihood of conversion disorder symptoms. So coming back to looking at the big picture, this little chart gives us a sense of how we can understand how the different disorders exist. So at the very top, we talk about simulated disease, or this idea of intentionally, not intentionally, but a disease process that appears to be a disease but doesn't have an organic or medical etiology. So on the left-hand side, we have those conditions which are unconsciously produced. So these we used to call somatoform disorders, and now we call them somatization disorders. But somatoform disorders, where we tend to see either predominantly neurologic complaints, as in the case with conversion disorder, or predominantly complaints of multiple organ systems, such as somatization disorder, or primary complaints, and this isn't on the chart, but of a fear of having a particular disease or condition, and that would be illness anxiety disorder. And all of these are unconsciously produced. On the other side of the chart, we see those conditions which are intentionally produced, and we would call these deception syndromes. In this case, the person is intentionally lying and intentionally misleading the medical professional. So we see the two types: one with external incentives such as financial gain for malingering, and then the other without obvious external incentives, but more internal or psychological incentives, and that would be factitious disorder. So one of the things I want to talk about is the big picture and how these symptoms and these disorders are connected across different groups of disorders. So one thing that you might observe with the somatization disorders is that anxiety is a common thread. So we often see panic disorder to be comorbid with somatic symptom disorders. So there's high rates of comorbidity. If you remember, panic disorders where individuals have panic attacks that come on out of the blue. Individuals with both panic disorder and those with somatic symptom disorders tend to be very sensitive to bodily symptoms and to misinterpret benign or normal symptoms in the context of pathologizing it. So thinking that their heart rate increasing is a sign that they are going to have a heart attack. There are a little bit of differences between the two. So with panic disorder, we fear immediate symptoms of the panic attack. And over time, these individuals learn very quickly that medical intervention doesn't help them. So they stop seeking medical intervention, and they may eventually seek psychological intervention when they realize there is no medical cause for their panic attacks. Now, some individuals with somatic symptom disorders will have concern over future long-term illnesses like cancer, and this would be the case of hypochondriasis. So it's not always immediate symptoms, but they're thinking more long-term. And also, in contrast to people with panic, these individuals will continue to seek medical intervention despite assurances that they're healthy. So individuals with illness anxiety disorder or hypochondriasis will persist in looking for a diagnosis that is not there, even across different medical professionals. Whereas on the opposite, those with panic disorder will actually give up seeking medical intervention when they realize it's not working. There's also some connections and overlap between somatization disorders and dissociation. And another set of videos, I'm going to talk more about dissociation. But dissociative symptoms are feelings of unreality, and dissociative symptoms are more common in patients with conversion disorder. So if you remember back to historically that Freud and Janet and others were looking at dissociation and how they were connected to hysteria. And in this case, we know that there is a connection between dissociation and some forms of somatization disorders, particularly conversion disorder. So before ending this lecture, I'd like to give you the opportunity to try out some practice questions. These are multiple choice questions that might appear on the test. So if you're ready, grab a piece of paper and we'll get started. So the first question is a little bit of helping you to distinguish between different disorders. The idea is, which of the following statements would be an example of those thoughts associated with a person suffering from somatic symptom disorder? So what we're looking for here is, what are the features of somatic symptom disorder? And we want to sort that out from other disorders such as illness anxiety disorder or conversion disorder or even factitious disorder. Okay. A sore throat is nothing to worry about unless there's a temperature along with it, then it's a big problem. B, a sore throat is serious and requires a trip to the doctor. If the doctor tests and finds nothing, it is okay. C, a sore throat is a major problem. It could be cancer or some other deadly disease, no matter what the doctor says. D, a sore throat could be a serious sign of cancer, but it would be important to wait until the doctor says one way or the other before panicking. All right, which answer do you think is correct? If you chose C, you're right. So how can we walk through this? Well, first of all, the answer A, a sore throat is nothing to worry about. Well, we know that there's going to be worry, right? And with somatic symptom disorder, so we can cross that off the list. B, a sore throat is serious and requires a trip to the doctor. If the doctor tests and finds nothing, it is okay. So what makes this answer incorrect? Well, the first part does suggest that there's a lot of anxiety about the sore throat, but the second part suggests that if the test reveals nothing, that the patient is fine. And that's not necessarily the case. Remember, these individuals will still have anxiety despite negative test results. D is, a sore throat could be a serious sign of cancer, but it's important to wait for the diagnosis before panicking. Again, these individuals are not going to wait for a diagnosis before panicking. They're going to become upset very quickly. So the best answer is C. Here's another question. Which of the following was once viewed as a form of hysteria? Conversion disorder, dissociative identity disorder, dissociative fugue, or hypochondriasis? You should know it's conversion disorder, right? Lastly, here's a little bit of a case study. Following the rejection of his latest novel, Jim experienced an inability to make some movements with his right hand. While he was unable to write, he could scratch and make other simple motions with his affected hand. 2 weeks later, he was able to write again. What is unique about Jim's case of conversion disorder? Jim has some ability to move his hand. Jim is male, and most people with the disorder are women. Jim's symptoms subsided after only 2 weeks. Jim only lost the ability to move his right hand. Well, let's go through this. The answer is B. Jim is male, and most people with this disorder are female. So that is the correct answer. But let's sort through this. What do we know about conversion disorder? So Jim has conversion disorder, right? Because he has these movements. So he can't use his hand to write, but he can use it to scratch. So that doesn't make sense, right, from a medical standpoint. So Jim has some ability to move his hand. Well, we would expect that if we're diagnosing conversion disorder, because remember, the symptoms don't make sense medically. So A is probably not the right answer. C, Jim's symptoms subsided after only 2 weeks. Again, we tend to see a sudden onset and sometimes a sudden resolution of these symptoms with conversion disorder. And that may be because the stressor that triggered the disorder actually subsided, or the person avoided that successfully. So C really isn't the right answer either. D, Jim only lost the ability to move his right hand. Well, there's nothing that says that individuals have to lose their ability to use both of their hands, right? So this doesn't really map on to any of the disorders that we've been talking about. Earl falls at work. The initial medical test shows no major physical problems. However, Earl calls the next day and tells his boss that he is unable to use his right leg because it is paralyzed. He also informs his boss that he plans to sue the company. Earl is most likely what? Malingering. What are the clues here? Well, there's no physical problem. He's talking about suing, which means that there is a secondary gain, financial gain. And he's faking having an injury that he's paralyzed. So he's also trying to get out of work, right? Because he's telling his boss he can't use his right leg. So conversion disorder, somatization disorder would not be involved because they don't involve secondary gain. And these are unintentional or non-purposeful symptoms. Factitious disorder, it could be factitious disorder, but what is the difference between factitious disorder and malingering? Well, the difference is that malingering is connected to external gain or secondary gain, such as suing the company for money, whereas factitious disorder is more of an internal situation, internal gain through psychological needs being met. So this is the end of this video talking about somatic disorders and somatic symptom disorders. And I hope that you found this additional information helpful as you learn about these disorders and read about them in your book. Thank you.